So I'm happy today to have the chance to introduce Dr. Ashley Wilde, who is the Director of Infectious Diseases Clinical Research Programs and Research for Norton Infectious Diseases Institute at Norton Healthcare. Dr. Wilde also serves as the lead for the Antimicrobial Stewardship activities for Kentucky, and the program is wonderfully named KASIC, Kentucky Antimicrobial Stewardship Innovation Collaborative. So happy that you're here, Ashley, to talk with us today about rapid diagnostics and antimicrobial stewardship. So let me turn it over to you.
Thank you, Dr. Carrico. As she said, my presentation today I titled Need for Speed, Blood Culture Rapid Diagnostics and Antimicrobial Stewardship. By the end of my presentation today, you should be able to state the blood culture processing steps followed in a clinical microbiology lab, describe the integration of blood culture rapid diagnostics into clinical practice at Norton Healthcare, and describe the impact of the Norton Healthcare Rapid Bacteremia Response Program, the program we created to encapsulate all of this. But before we get into all the modern technology that is rapid diagnostics, it's important to know where we started so we can appreciate exactly how far we've come. And that takes us all the way back to 1884. So 1884 was a big year in the world of microbiology because Hans Christian Gram, maybe Gram, published his Gram staining method. If you think about it, Gram staining might actually be the original rapid diagnostic technology. This tool provided important but limited information as to the causative etiology of a patient's infection. Now, I call this presentation Need for Speed, partly to get you into the mindset of rapid diagnostic technology, but also because right around this time in the late 1800s, another important breakthrough in the world of speed was unveiled, and that was the assembly of the very first motor car, so the Benz patent motor car. This car had a total engine output of 0.75 horsepower. Now, I think it's an important comparison to make considering how much has improved in the world of motorsports, and yet we still use Gram stains today in every microbiology lab. Now, fortunately, a lot has improved in the world of cars, and a lot has improved in the world of microbiology as well. And I'm not going to give a history lesson of all the rapid diagnostic technologies, but rather I'm going to focus on how blood culture rapid diagnostics were integrated into clinical practice to create the Rapid Bacteremia Response Program here at Norton Healthcare. So to get the full picture of how these technologies can help patients, I want to take a moment to review how blood cultures are collected and processed. And that all starts with our patient. We have a patient with a suspected infection. And after a thorough clinical review, a provider orders a set of blood cultures. So for most adult patients, when we order blood cultures, we actually get two bottles, an aerobic and an anaerobic bottle. And these are not regular bottles. They have special media inside them and gases inside them to really help encourage bacteria to grow. Because in blood, in bacteremic patients, there's still very, very low concentrations of bacteria in there. So if we were to do any direct testing from that, we wouldn't be able to either find any on Gram stain, it wouldn't grow on any plates. So we have to do additional incubation. So these blood culture bottles, after we obtain a sample, are placed on a special incubator, and these all work together in a very nifty system, since we have to wait for these bacteria to grow. So the incubator gives it a nice warm environment for the bacteria to grow. But these special incubators, as you can see modeled by our lovely model here, work in these big machines that periodically detect for bacterial growth. And the way that they do that is as bacteria replicate inside those blood culture bottles, they release CO2. Now the CO2 will drop the pH in that bottle, and there's a special membrane in the bottom of those bottles that will start to fluoresce when the pH drops due to that CO2 being released. So it shines a light in there to detect whether or not bacteria are growing. And if it finally does detect some fluorescence, it'll alert the technician, as you can see here, to open that particular drawer and pull out that specific bottle. That way we know we have a positive blood culture. So from that moment, we then are able to take it over to our Gram staining station. Now you'll have to excuse these pictures. These pictures are about 5 years old. The microbiology lab here at Norton Healthcare has since moved, but as you can see, that same process from 1884 is still used commonly today. Now we can get that information about what the Gram stain was, either positive or negative, or the shape and the arrangement. So we know if it's a cocci or a rod, if it's in clusters or in pairs, and that information can be communicated, which is very helpful. But in a traditional clinical microbiology lab, that's the amount of information that we can glean at this moment. So then the next step is we have to get that bacteria to grow then onto agar or plates. So we take the blood that's now full of lots of bacteria, spread it on a plate. Here's just a picture of a variety of different media used for different types of tests to isolate other different types of organisms. But then these plates, after you smear it with that blood sample that now should be full of viable bacteria, and it goes into an incubator. Now the time from these steps can vary depending on what the pathogen is. Most bacteria will grow within that bottle typically within a day, sometimes less, maybe like half a day, sometimes a little bit longer, but for the most of the bacteria that we're talking about, within a day or so, if it's going to be positive, it will be positive by then. We hold them for a few days longer. You know, the amount of bacteria that are in the blood at the time that it was drawn will affect how long it takes to turn positive. Whether or not the patient had received antibiotics prior to blood culture drawing might affect the time to turn positive. But again, we're looking usually at about maybe a day, maybe half a day before the blood cultures turns positive. Turns positive is when we do the gram stain. And then we have to have it grow on the agar again, which is typically left in the incubator overnight. And then these fine technicians then have to read each of the individual plate to see if the bacteria has grown on that agar. And at least previously, this was a very manual process to look to see where the colonies had grown. When they detect growth, they then take it over to those susceptibility and identification panels that Dr. Junkins presented a little bit about last week. So we talked about these MicroScan panels. MicroScan is what we happen to have here at Norton Healthcare, but it's a panel with individual wells that either have different concentrations of antibiotics in them to assess for susceptibilities, or it might have a few tests to help identify the organism based off of biochemical analysis. So as you can see here, our technician is then taking the samples from that agar. She's loading a purity plate. You know, one of the things that Dr. Junkins mentioned last week was that if you get a susceptibility test that doesn't make sense, oftentimes there might be some contamination. So if you have a gram negative mixed in with a gram positive, when you do susceptibility testing, you're going to get a lot of resistance since typically those are not the same antibiotics that we use. So at the same time that they're loading up these susceptibility panels, they're also streaking some purity plates. Now then they create a suspension of the bacteria that they load into that panel so that you can see her sucking up all those wells all at once. So fortunately, she doesn't have to individually pipette each of those tiny wells. But then after those bacteria are loaded onto those panels, those go into the automated susceptibility testing machine. So again, at Norton Healthcare, we have the MicroScan machine, and there it is sitting in all of its glory. You can see, and you open it up, you can slide the panels in, and then it further incubates that bacteria within that tray. And then this machine has a variety of tools that it uses to identify growth based off of turbidity or cloudiness within those wells, or if there was a change in color in some of those biochemical results. But then it will give you a readout of the report that typically gives you the organism's susceptibility report, so which antibiotics it would consider susceptible or intermediate or resistant. And then if it also is an identification panel, then it would also let you know that this is in fact whichever bacteria. Now, this is sort of the traditional blood culture workup process without any additional molecular rapid diagnostic technology. At this point, unless something really weird happened, like it was a really difficult to identify organism or needed some additional susceptibility testing, then this is considered the end of the process. And the results that we get from the MicroScan machine or whatever automated susceptibility testing machine would then be reported in a computer system. So I'm going to talk briefly about how we reported the information that was gleaned from all of these steps in the microbiology lab. And this is going to be outlining what we did before 2017 when we implemented that rapid bacteremia response program. So it starts again with the patient when we draw up the blood cultures and incubate it. Once it has been flagged as positive by our blood culture incubators, at that moment, two things happen. The first is that we gram stain it, and that gram stain result is called to the bedside nurse. And then the bedside nurse would contact the prescriber with that result. So you have communication from the central microbiology lab to the nurse that's taking care of the patient, who then contacts the appropriate provider to relay those results. At the same time, they also, as I outlined previously, take a part of that specimen, put it on a plate, allow it to grow, typically at least overnight. And then once it's been growing on the plate, load it on the MicroScan panel, and then typically again about another day before we get the full susceptibility results. So if you think about the processes that happen, that's very similar to most acute hospitals. But when we implemented the Rapid Bacteremia Response Program, we did two things at the exact same time. The first was that we adopted a new technology, which we had the Verigene System, which I'll talk about in a moment. And the second was we made a significant change on how these results were reported and acted upon. But first, let me talk a little bit about the Verigene System. This is just one of a few systems that are out there commercially available for clinical microbiology labs. Verigene uses gold nanoparticles to identify very small parts of DNA or RNA from those positive blood cultures. It's not a PCR, but a lot of people understand the concept of PCRs nowadays, thanks to everybody's crash course in infectious diseases technology through COVID testing. But rather you can think about it, excuse me, in a similar way where we don't rely on the bacteria to grow, but rather we are detecting specific pieces of that bacterial RNA or DNA. And I point out here that it does have to be tested on positive blood cultures. So we can't take blood directly from a patient and run it on this platform, but rather this Verigene and as well as the other rapid molecular diagnostics are run once we know that blood culture is positive. Part of it is because the quantity of bacteria isn't enough, but also what's nice is that you're not wasting these tests on blood cultures that don't actually have any bacteria in them. But you can see from this diagram how much it cuts down on time to at least some knowledge about the patient's blood culture. So for a traditional blood culture workflow, you have to culture the blood, and then once we know it's positive, you gram stain it. Then it needs to be plated for subculture, and then we have to put it on the susceptibility testing machine before we get full culture and susceptibility results. With a Verigene machine, you still have to incubate it and get the gram stain. But then after that, in about 2 to 3 hours, once you load onto the Verigene, you will be able to get some additional information about that particular bacteria. With the Verigene system, there are 2 different panels. We have a gram-negative bacteria panel, as well as a gram-positive bacteria panel. And each of these panels gives us a variety of targets. So for example, both of these have organism identification for common species. Sometimes we can get down to the genus or species level, depending on the organism. Both of these also have a variety of resistance genes. So for example, for the gram-negatives, we can detect CTXM, which is one of the most common ESBL genes here in the United States. And then we also have a variety of genes that encode for carbapenemase, which may mean the organism might be a CRE for those IPs out there. From the gram-positive side, the resistance genes we can detect include a MEK-A gene, which encodes primarily for methicillin resistance. It's our primary methicillin resistance driver for Staph aureus. And it also can detect VAN-A or the VAN-B genes, which can encode for vancomycin resistance in Enterococcus species. So it is still limited information, but a lot of helpful information when it comes to our causative pathogens. So the benefits of having these technologies is that we actually might be able to de-escalate patients faster. Oftentimes, the most common gram stain from blood cultures is GPCs in clusters. And when we have a GPCs in clusters, it could be anything from a contaminant like a coagulase negative staph that likes to live on your skin but isn't particularly virulent, doesn't like to cause infections, or a GPC in clusters could be Staph aureus, which is one of the most ultimate human pathogens that causes such significant morbidity and mortality. But we can also detect some resistance mechanisms that might help us target antibiotics faster. So we talk a lot about antibiotics for MRSA, but vancomycin being our primary antibiotic for MRSA is actually not as good when it comes to the treatment of methicillin susceptible Staph aureus. So if we know that a patient is affected by an MSSA, so a susceptible Staph aureus, not only could we get them off broad spectrum antibiotics, but we can actually get them on more effective antibiotics faster. For those that are thinking about escalating therapy, we actually might be able to get patients on effective therapy faster because of the fact that we would be able to identify something that's more difficult to treat, like Pseudomonas or Acinetobacter, faster. We don't often empirically treat somebody for some of these more drug-resistant gram-negatives, so knowing about this faster will help us get them on effective therapy. And last but not least, we also have faster time to contact isolation. So if we know that the organism infecting somebody's bloodstream is an ESBL or potentially a CRE, we can put them in isolation sooner than waiting for this full susceptibility report. Those are some of the benefits, but of course there are limitations of this machine. The first and foremost is that most antibiotic susceptibilities remain unknown. The genes that we get give us some information about what antibiotics we could use, but oftentimes we're left either using our antibiogram or looking at the patient's past susceptibilities to make our best guess as far as which antibiotic to use. It does not, therefore, replace the full identification and susceptibility. Sometimes, I mentioned we don't get the full antibiotic susceptibility, but sometimes Verigene doesn't know what the bug is. It's something that wasn't on one of our panels. So ultimately, we still have to do full ID and susceptibility, which means for the microbiology lab, we're not replacing any of their work. We're just adding some more work for them to do. Also, with the Verigene, you can get some very complicated results that are left to the interpretation of the provider. Right, so I mentioned we have sometimes this genus or species level, but there's a fair number of times where the Verigene might detect that it is in fact the Staphylococcus genus, but it's non-aureus, non-epidermidis, non-londinensis. Oh, and by the way, it's MEK positive, so good luck with that, right? And if you just report that information as that is, people may not know what to do with that. And last but not least, it does have some difficulty with polymicrobial specimens, which is important to note, especially if you have a source of the bacteremia where you might suspect more than one bacteria. But you know what? Like, knowing more is better, right? Like, having more information faster is just going to improve patient care. This actually may not be the case. I think it's very interesting that a prominent clinical pathologist, Dr. Raymond Bartlett, who actually worked at Hartford Hospital, published a book back in 1974 called Medical Microbiology, Quality, Cost, and Clinical Relevance. And this brought a lot of controversy among physicians because he criticized this really entrenched practice in the field of clinical microbiology that he thought was very wasteful and possibly clinically misleading. And in his book, he said, quote, "Our technical capacity are exceeding our ability to apply them effectively and economically to human problems, and that the microbiology lab today is, quote, faced with a superabundance of academic information and pressure to perform exhaustive, expensive, and clinically irrelevant testing." Now, think about this. This was 1974. They're saying, like, you know what, this is getting too much. This is getting too complicated. But 90 years after the development of gram stain, like, you'd think we'd have all of our technology worked out, right? We would have been able to build on something that is both effective and clinically relevant. But really back then, even before all these truly molecular diagnostics, it was getting exhaustive for both the microbiology lab side and then the clinical practice side. But maybe to keep up with our analogy of automotive industry with rapid diagnostics and microbiology, maybe we didn't figure it out on the micro side, but maybe the automotive industry had made better progress. Does anybody know what the top selling car in the United States was in 1974? I won't call anybody out if they happen to own one. But in 1974, not the fastest car, but the top selling car was the Ford Pinto. This actually had, I see David celebrate. It had 100 times the horsepower that of the Benz patent motor car. At 0 to 60 speed was 12.2 seconds. This sounds really great, and obviously there was a lot more consumer-driven technology back then. But despite these advancements in speed, looks like there was still room for improvement there because, as you might know, despite all of this, there was a universal recall after the fact that the fuel system design may cause leakage and explosions if it was rear-ended. So looks like we still had to go a little bit past the 70s in order to get this right. And the way we work with a clinical microbiology lab, at least, is to bring in diagnostic stewardship to help providers and clinicians order the appropriate tests. And the way this interplays between the patient and the microbiology lab is a combination of both diagnostic stewardship and antimicrobial stewardship. So when starting with the patient, I mentioned we have to have a provider do a thorough clinical evaluation. A diagnostic stewardship program is designed to aid the provider in ordering the right test for the right patient at the right time. And when it comes to that rapid diagnostic technology, then is performed in the microbiology lab, then the results are reported and helped interpreted through this stewardship program in order to get the right interpretation of the result, to get the patient the right antimicrobial at the right time to aid in diagnosis and treatment. Now, when it comes to rapid diagnostics and blood culture technology, diagnostic stewardship end of the spectrum is not as big of a deal because, like I said earlier, we only perform this particular rapid diagnostic test on positive blood cultures. So it's not something that we have to consider whether or not this patient has a high likelihood of having a positive blood culture at the time of ordering the blood culture. So stewardship of the rapid diagnostic test, at least in this particular case, is not as relevant. But I do want to talk about the role of antimicrobial stewardship programs as it relates to blood culture diagnostics and aiding in the interpretation and the linkage between the microbiology lab and the patient. And luckily, this has actually been studied and published on extensively. In fact, a few years ago, there was a systematic review and meta-analysis on the effect of using these molecular rapid diagnostic tests on clinical outcomes in patients with bloodstream infections. And I'm not going to go over all this in detail, but the conclusion from this meta-analysis was that they found an odds ratio of mortality was reduced only if this molecular rapid diagnostic technology was combined with an ASP, so an antimicrobial stewardship program. They actually did not find a difference when you implemented a rapid diagnostic technology in the microbiology lab without the aid of that stewardship program. Overall, they found that a number needed to treat to prevent one death at 30 days was 20. Obviously, there's a lot of different rapid diagnostic technologies out there. There's a lot of different approaches to implementing those results. Sometimes it's 24/7, sometimes it's Monday through Friday, so it's tough to say like whether or not one approach is better than the other. But implementing a rapid diagnostic test really needs to consider a lot of things that are individualized to your own institution. So when you're considering how to implement these things, resources tend to be a big question. So batched testing versus on-demand testing can really improve the efficiency of your clinical micro folks. But of course, if you're batching your tests together, you are losing part of that rapid diagnostic part. So if you can only run it once a day or twice a day, you might have tests that are waiting for that rapid result. Communicating the results can be really tricky, right? So if you want to report the results within the EMR, the wording has to be carefully conveyed, since more isn't always better, and helping people who don't speak resistance mechanisms and are used to looking at the S and the R, and that was their entire world of interpretation. Implementing some of these rapid diagnostics that does not give the same context can be challenging. Thinking about who should receive the results, is it best to call that bedside nurse? That can be very challenging, especially if there's a lot of pieces of information to convey. It's one thing to say it's a gram-negative raw, but it's another thing to result all of the details from some of these sophisticated reports. Contacting a provider would be useful, but can be very challenging to notify in a timely manner. And obviously, if you have an infectious diseases specialist, being able to give them the direct results would be likely the most beneficial, but not every institution has access to infectious diseases specialists or even a specialist 24/7. We also have to consider if the results of the test will be accepted. So, does the medical staff understand this technology enough to trust the results? And do they understand the limitations of this result? One of the things that we were really concerned about is if the Verigene wasn't able to identify the organism, it wasn't one of the several that were listed in that previous table, will they interpret that as the blood culture is negative because we didn't give them a name of the bacteria at that moment? And whether or not they would accept our recommendations as far as making adjustments, either starting or stopping antibiotics. A lot of that needs to be considered when implementing these programs. In general, there's two approaches. You can take the low resource approach where you have a guideline or a protocol, some sort of pocket card that helps people interpret the results, which can give you at least some information that can be quickly disseminated and potentially universally applied. Or you can take a high resource approach where you make personalized antimicrobial stewardship decision support. It takes into consideration the site of the patient's infection, takes into account their individual antibiotic allergies, prior antibiotic exposures, past cultures and susceptibilities, whether or not they have drug-drug interactions, and what dose to use to treat their infection. So obviously, as a pharmacist, you can see which way I was leaning, but that brings me back to the second part of what I talked about when we implemented this rapid bacteremia response program, which was a change in the reporting of information. Before implementing a change, it's always important to understand the performance at current state, and current state I meant as pre-implementation. So to do that, we had completed 2 separate quality improvement projects that evaluated the time from positive blood culture gram stain to start of effective antibiotic therapy in patients who were not already on antibiotics. So the idea is that if this was a new piece of information that would change our treatment. And what we found was that there were significant delays between the time that the gram stain was reported to the start of effective therapy. On average, it took about 10 to 12 hours from the time that the gram stain was reported to that bedside nurse to when an antibiotic was infused, if the patient was not already on antibiotics. And I have it broken down here as far as what the average delays and what it was attributed to. So from starting at time 0, this big blue bar here is the time between the nurse being notified of the positive gram stain result to an antibiotic being ordered. So, if you remember, the nurse would contact the provider would call back, they would either enter the order themselves or give a verbal order to the nurse. But that was the vast majority of delay, was getting a hold of a provider. This skinny little red bar is the time from the order being entered into our electronic medical record, so a pharmacist verifying the order. But then this bigger green bar here, which was about an hour, was the time between the pharmacist verifying the order and when they decided to schedule that antibiotic. Since it is fairly customary that a pharmacist will delay the start time for an antibiotic because it requires time to prepare, deliver, and get it in the nurse's hands. So that was the green bar, was a scheduling delay. And then this last delay was administration delay. So the time that it was scheduled to be given to when the nurse actually gave the antibiotic. And for those of you who understand bedside practice, there's all sorts of reasons for having delays, right? There was a patient having a procedure done, or maybe it was shift change for nursing and they didn't get it started before they had to give report. There's a variety of reasons for why antibiotics or drugs may not be infused on time. But part of the reason was they may not have known of the urgency of this particular antibiotic. So with our rapid bacteremia response program, we thought we could do better. And so to incorporate both that rapid diagnostic technology and this, we came up with the rapid bacteremia response program. So the positive blood culture result is actually called to the central pharmacy, who orders a stat dose of an antibiotic per protocol without calling a provider, only if the patient was not on effective therapy. At the same time, that positive blood culture was then put on the Verigene system. Those Verigene results were called to central pharmacy or the stewardship pharmacy, and then the pharmacist notifies the provider with a recommendation. And last but not least, don't forget that we still have to do the standard susceptibility testing. And so we thought that we could get antibiotics in faster. And if you remember from pre-2017, we wanted to get our first dose of antibiotic from the 12-hour or the 10 to 12-hour mark down to under an hour. So this is our little window to get the antibiotic, Verigene processing, and then we hope to have optimized therapy by then. So we collected data prospectively in the first year for all adult patients who had a positive blood culture. And overall, we had over 2,000 patients with positive blood cultures with just over 2,000 Verigene results. Stat antibiotics by the pharmacist were given in over a third of our patients, which means when we got that gram stain result, the patient wasn't on effective therapy and we got their antibiotic in stat. Now, the time from gram stain to start of infusion, which is what we were hoping to improve upon, if you remember I said the baseline historical data took us 10 to 12 hours. Well, after implementing the RBRP, our median time to antibiotic therapy was 51 minutes. So several hours faster, making it part of our rapid response. And what's interesting to note is that our fastest time to antibiotics, so from the time that we get the gram stain result to the nurse starting the infusion, was 7 minutes. We can't even get a code started sometimes in that long if you have to make it all the way over to the next building. But just really goes to show the efficiency of cutting out some of those processes. Also, based off of those Verigene results, we made a lot of interventions as well. So of those 2,000 Verigene results, over half of them resulted in a change to their antibiotic regimen. Over 20% had antibiotics escalated. Several of them had their doses optimized based off of their indication. And then we also de-escalated antibiotics in about 20% of our patients. And for those of you who are infection preventionists as well, when we had identified a resistance gene, we also placed our patients in contact isolation, and that happened 135 times. I won't touch on this too much, but we also had a standing order to order repeat blood cultures when it was gram-positive coccidiosis clusters, and the frequency at which we did that increased to 92%, which is a 2.44-fold increase from baseline. So is faster better? You know, I said we can get patients antibiotics faster, and we can have lots of conversations about that. But when you're looking at the fastest car that was available on the market in 2017, it was the Tesla Model S P100D. Now the P100D can go from 0 to 60 seconds or 0 to 60 miles per hour in 2.3 seconds with 680 horsepower. But you know, in clinical practice, we don't want flashy things. We don't necessarily want, you know, gimmicks. We want better patient outcomes. And one of the things that we were able to do with the help of Dr. Ramirez and his group was to look at patients that had community onset Staph aureus bacteremia before and after the implementation of this rapid bacteremia response program. And overall, what we saw was a reduction in length of stay, as shown here, but we were also able to reduce mortality. So we did not see a change in in-hospital mortality, but when you looked at our 30-day mortality, we reduced from 19% mortality at 30 days pre-RBRP down to 3%. And this actually results in a number needed to treat to prevent one death at 30 days of 7. So we thought this was really neat, and we weren't the only ones. And so back in 2019, we were very fortunate to be recognized as recipients of a Best Practice Award from the American Society of Health System Pharmacists, so ASHP. For those of you who don't know ASHP, they are the largest hospital pharmacy organization in the world, and they are the primary organization that drives pharmacy policy and practice within health systems. And each year they recognize practitioners in pharmacy who have successfully implemented some of these innovative systems that demonstrate best practices. So you might see some faces you might recognize. Matt was presenting not too long ago here as well. So in conclusion, and I'm trying to make sure I don't go too much over, you know, rapid diagnostic technologies have really revolutionized the clinical microbiology lab. If you ever have the opportunity to take a tour of the microbiology lab with Dr. Junkins, I highly recommend it. He does a lot of cool work and has a lot of interesting technology there. But when you're considering whether or not you should implement a rapid diagnostic tool at your institution, you really need to consider how it needs to be tailored to your needs. But then antimicrobial stewardship programs are key to achieving benefits, particularly with these blood culture programs. So even the time that it took us from the date in 2017 to implement this to today, there's even faster technologies, both in the microbiology lab. There's a Verigene 2 system now. There's rapid diagnostics that can give you almost full susceptibilities from blood cultures. The technology is definitely advancing in clinical microbiology, but is it at the same pace as, well, motorsports? You know, probably not. The Model S Plaid shown here can go 0 to 60 in under 2 seconds and has over 1,000 horsepower and can drive itself. So hopefully we will get there someday in healthcare technology as well. And last but not least, I want to acknowledge Dr. Junkins and his work with implementing this program and answering all my questions, and then also to his staff that acted as models for me for this picture. So with that, if you have any questions, I'm happy to answer them now.
Actually, that was very good. I put a note in the chat just from people that are on the webinar. How able have you been to arrange a time to go through the micro lab that runs the test for your facility? I know we have a number of folks on the call who work in long-term care, and they may send their micro out. So the value of doing exactly what you talked about in every place where our group is providing care or responsible for infection control. This is a really good point to know what is happening and be able to establish those relationships. So if you have any questions, put those in the chat, and let me, Dr. Ramirez, I know you always have plenty of questions to ask, and I don't want to miss the learning from your questions. So
No, but while we wait for questions, I'm since Ashley, since you are directing the CASIC program, and we're looking at how to help institutions with low resources. You mentioned that you use this applying in an area of high resources. How do you see a program like this in the implementation if you were to be in a low resource area, even though probably the low resource is also is going to apply to personnel, but also to microbiology. But let's assume that this place, microbiology, has a rapid diagnostic capability. How do you see implementing a rapid bacteremic response in an area with low resources?
Yeah, that's a good question, because when it comes to antibiotic optimization, there's a variety of answers that are right. So you could have an antibiotic that's effective, and then you can have an antibiotic that's effective and the most appropriate as far as like the most narrow spectrum. And I think the more resources you have, the closer you're going to be able to get to what I consider like the best therapy, right? But knowing that at a minimum, the patient is on effective therapy based off of that results, it can be actually very protocolized. You can develop algorithms to say, like, if the result says this, these are one of the antibiotics that will be effective when this pairing comes up, so to speak. And so one of the things that we did, and this could be something we can definitely help other organizations with who are interested in implementing this, is sharing some of those tables that we created based off of our own information or based off of information that they might have on their own antibiograms. So one of the things that we created, and I mentioned it before very briefly, was, if a patient has a result for, let's say, E. coli that's doesn't have a CTXM. Like, I have a list of antibiotics that I will say these cover at least 85% of our isolates. And so it truly is matching up, is this patient's therapy adequate? So at a minimum, you can get somebody on adequate therapy faster. And then down the road, if you have certain personnel who may be able to say, for this particular combination, our first line recommendation is X. And honestly, one of the things that we did here was make this 24/7. So it's not me, an infectious diseases trained pharmacist interpreting results. We have our third shift pharmacists communicating Verigene results, often to overnight staff there might be a mid-level hospital provider covering for the hospitalist overnight. And they're making recommendations based off of a table that says, okay, for, MRSA, our first line antibiotic is vancomycin. If they're not on vancomycin, I recommend you starting vancomycin. So simple tables that don't necessarily require individualized interpretations, at a minimum, can make sure that they are on effective therapy, but potentially even take that next step to optimize therapy. Since one of the big benefits that we saw was able to get people on the right scope of therapy.
If you were in a small hospital and they're still using the traditional microbiology, and let's say it takes 2-3 days to identify an organism, they are going to be, micro is going to be calling the nurse, and the nurse will try to figure out where is the doctor, and the doctor will answer at a certain time, and the doctor will get the information. Then it will be the case that this rapid response, it may also benefit even a hospital with traditional microbiology?
Absolutely. That first dose of antibiotics was all driven by the gram stain, right? So you don't necessarily have to have any clinical interpretation. It is a true algorithm of, if this gram stain, then this. So you don't have to consider necessarily what the site of the infection was or what the likely pathogens are based off of that. It was truly a trigger algorithm to give somebody something to get them started. There was probably more patients of ours that got a dose of vancomycin who ultimately had a contaminated blood culture, right? So it was a coag-negative staph. By the time we identified that through our Verigene, we said, yeah, sure enough, this patient doesn't have any signs of systemic illness. And, I'm not sure why we got blood cultures, but we didn't need that. but rather when that gram stain results and it's GPCs and clusters, you can start somebody on effective therapy faster. And that does not require the rapid diagnostic technology and doesn't necessarily require clinical interpretation. So if an organization wanted to take that approach to develop a standing order, that's what it was designated here at Norton Healthcare, as a standing order for somebody to initiate a, if this, then this, that would be within something, a protocol that, or a standing order that an organization could implement if communication with a provider, delays in communication, is primarily driving their delays to getting them on effective therapy.
Ruth, do you have any questions from the?
No, nothing else from the chat. I think several people have been interested in trying to figure out how they can come and tour the lab. That I think, the pictures of what you've done and really description help to really, I think, invigorate the interest in doing what I think has been happening in the past, and that is we can do our job better if we really understand the job that is being done by others. And so that idea of taking a look at the micro lab, I think is great. And I put my email in the chat if people are interested. And want to do that, I can contact Dr. Junk and see how that could be possible. And then I'd be able to use this as a way of showing this is what is done in this health system. And then people can make that relationship to what they're doing in their facility.
Yeah, the microbiology labs always have this big black box. So if you send samples and then you wait, and then eventually information comes out. And part of the reason I explain all this is because I knew when I started in clinical practice, it's just, you just wait for blood culture results. You don't appreciate all the steps that are happening behind the scenes. And who knows what at what point really helps provide, like you said, some of that context about like, what am I waiting for?
I want to, since you have the experience of going through this program in a large healthcare setting, and again, this is, you can be talking for a long time, but what would be the message, the most important message? They say, I'm in this small hospital. I hear this presentation. This is a good idea. Looking at the gram stain, I mean, and it's difficult to find the doctors. It takes hours. I can really impact patient care by doing this. But the question is, how do I convince my local physicians that now a non-doctor, a non-MD is going to start antibiotics?
Yeah, I think part of it is like having clear communication. So one of the things that I don't touch on here is how we document what we're doing step by step. So every time we get a gram stain result, we do not contact the provider, but we do leave a note in the medical record so that they know like what the gram stain was, what antibiotics they were on, what, if any, we did. So if we started a dose of vancomycin, we ordered repeat blood cultures, we detail that. So there's a standardized documentation template so that if a provider wants to know what's been going on, they can see that. And then they get notified at the moment that we have the Verigene result. And then we, again, both communicate with them verbally, but then also document our conversation with our recommendation. So we do convey to them, this patient has an E. coli that has a CTXM gene, therefore it's an ESBL E. coli. We started this patient on cefepime. However, because of this gene, we recommend to start them on whatever formulary agent you have. And so all of that is documented if they so choose to know about what's going on sooner. I will say that there was some heartburn about not knowing when a patient was started on antibiotics. But when it comes to like the two things that were most powerful for me when we were implementing it was having that baseline data to say that the status quo was not going to be acceptable, right? You can say that doctors want to know and they want to be involved, but at the expense of delaying antibiotic therapy to the patients from a systematic approach at an organization our at large was not acceptable. Then the other part was that when we do implement this, we were able to convince them that having one contact point, one point that we contact them with the most information will really help them get the best picture, since when you have a delay between gram stain and Verigene result by several hours, a lot can happen between then. You know, we might have shift change between pharmacists or physicians or nurses, or we might have the patient move around or something might happen between then. And they ultimately decided that having one call when the most action was going to be able to happen really streamlined their process. So communication was probably the biggest barrier, not necessarily somebody starting antibiotics without them knowing. So figuring out who your physician leaders are to get them engaged about improving status quo, or what is considered standard practice at your institution, really helped drive that to the point where we were so convincing with our ideas and of workflow and interpretation of this results that we even had some doctors that said, why don't you just change their therapy, and then just, you understand these genes better than I do, you understand the antibiogram and the susceptibilities better than I do, like, just change it, don't call me. And I'm like, well, that seems wrong. So we had to backpedal a little bit to make sure that we kind of had that happy medium. But honestly, communication, and then ultimately, once they started doing this, they loved it. They really appreciated the streamlined communication, the actions that happened to the patient. They understood what was going to happen. They appreciated our assistance to make it very, very standardized.
Very good. Well, Ashley, again, thank you very much for this great overview of the topic. As always, we're all available if anyone wants to start something like this. Ashley is also available.